We're now going to move on to range of motion of the shoulder. But before we get started, I think it's important to realize the shoulder moves from a couple of different spots. The glenohumeral joint accounts for about 120 degrees of the range of motion of the shoulder, and the scapula moving on the thorax accounts for the last 60 degrees. So as Jen abducts her arm, the first 120 degrees are due to this glenohumeral joint, and then the last 60 degrees are that scapula swinging out on the thorax. We're now going to get into formal active range of motion testing. And when you're doing this, you want to look for two things: the smoothness of the movement and the extent of the movement. So we'll have Jen start by abducting or abducting her hands above her head. Now the first 60 to 120 degrees, pain there would commonly be due to problems with the rotator cuff or impingement. The last 60 degrees of abduction, if the patient complains of pain there, it's often due to the acromioclavicular joint. Now we'll have Jen drop her hands just behind her head and push her elbows back. This is an important position to test. Functionally, it's important for doing your hair and doing other things behind your head. We'll ask Jen to bring her arms back up above her head, turn her palms out, and now we'll just drop her arms down to the sides slowly. Again, pain between 120 and 60 degrees is called a painful arc and is often due to rotator cuff muscle pathology. Now if someone does have a tear in the rotator cuff, Jen's going to demonstrate how they'll commonly abduct their shoulder. They'll elevate the trapezius and then bring the arm out and up above their head. We'll ask Jen to put her arms back down to the sides now. And with her left arm, we're going to ask her to reach across her body and touch the opposite shoulder. This is actually called the scarf test. It's an important functional maneuver for dressing and bathing, but also stresses the acromioclavicular joint. We'll have her do it with the other side. If the patient complains of pain doing this, it can be often due to problems with the acromioclavicular joint. We're now looking at Jen from the lateral position. And in this position, we're going to ask Jen to flex her arm up above her head, and it should flex up to 180 degrees, and then extend her arm back behind her head, and it should go to about 55 degrees. It's important to be able to flex your arm above your head, to work above your head, and also to drive a car. We're now going to look posteriorly, and this time we're going to ask Jen to reach up with one arm at a time and scratch as high up as she can on her back. This tests internal rotation and adduction. So again, internal rotation and adduction. And this is an important functional maneuver for doing up your bra or scratching your back. Staying in the posterior position, we're going to ask Jen to do a push-up on the wall. And here we're going to zoom in, and what we're looking for here is any winging of the scapula. Now winging of the scapula can often be due to a problem with the lateral scapulothoracic nerve. And you can see there's a little bit of winging on the left side as compared to the right. To be complete, we're going to test internal and external rotation. We'll ask Jen to flex her elbows to 90 degrees and externally rotate her arms out, and this should come to at least 55 degrees. We'll ask her now to internally rotate her arms, and again that should come to about 45 degrees. We're going to now move on to passive range of motion. Now to be honest, if active range of motion is full and smooth and complete, there's not much to be gained from doing passive range of motion. I find it useful to feel for crepitus and just feel the end feel of the range of motion. So with Jen's arm, I'm going to put my hand just on the acromion. I'm going to bring her arm up and abduct it, and I can feel that soft end feel and abduction. I'm going to externally rotate her arm and internally rotate the arm, looking for a range of motion and crepitus in that joint. We're now going to move on to special tests and stability testing of the shoulder. The shoulder joint is a little bit like a golf ball on a golf tee. It allows for great range of motion but inherent instability. You can think of the glenoid as a golf tee and the humeral head as a golf ball here. The muscles that hold that golf ball on the golf tee are called the rotator cuff. Now on Jen's shoulder here, we've drawn the acromion, we've drawn the humerus and the humeral head, and we've drawn the glenoid fossa. We've drawn also in red here a vector. Now, as Jen abducts her arm up, you want to hold that humeral head in the glenoid. If that humeral head starts to migrate superiorly, it will catch the tendons and structures underneath the acromion here and pinch them. Structures underneath the acromion include the rotator cuff muscles and the subacromial bursa. And this is what happens when we talk about impingement. Now we're going to move on to tests for impingement. The first test I like to do is just holding the acromion down and passively abducting the arm up to see if Jen has any pain and if we can impinge the tendons or bursa below the acromion. Second test we can do is called Neer's test. We're going to again hold the acromion, bring the arm up into full flexion, and just internally rotate the arm, again to see if we can pinch those tendons and cause pain. And finally, we're going to bring the arm down into 90 degrees of flexion, adduction, and then internally rotate the arm, and this is called Hawkins maneuver, to see again if we can cause impingement in that shoulder. Again, impingement is a very common cause for shoulder pain. We're now going to move on to formally testing muscles of the rotator cuff, starting with the supraspinatus. Now there's two tests you need to know: resisted isometric abduction and the empty can test. We'll start with resisted isometric abduction. We'll get Jen to flex her elbows to 90 degrees, or bring her arms out to about 15 degrees, and she's going to resist us as we try to push her arms down into her sides. This test is often done best from behind the patient. Now there's one other thing that's important to know about this test is you don't want Jen's arm moving. As soon as the arm moves, if Jen has pain, you're not sure if the pain is coming from the tendon you're trying to stress or from the joint moving. The next test we're going to do for supraspinatus is the empty can test. And I've got a pop can here I'm going to put in Jen's hand. She's going to bring her arm out in front of her and turn her hand over, like she's emptying the can, hence the empty can test. And in this test now we're going to stress Jen's arm down, she's going to resist us, and see if there's any pain with that maneuver, and that would be indicative of supraspinatus problems. Again, you always want to test both arms at the same time. The next muscle of the rotator cuff we're going to check are the infraspinatus and teres minor, and that's with resisted isometric external rotation. So we're going to get Jen to flex her arms again to 90 degrees and just externally rotate them. And she's going to hold them in that position, and I'm going to try to internally rotate her arms back. Again, you want this test done isometrically so the arms aren't moving. Testing infraspinatus and teres minor. We're now going to move on to test the last muscle of the rotator cuff, the subscapularis, and we're going to start by testing resisted isometric internal range of motion. So we're going to get Jen to flex her elbows to 90 degrees, internally rotate those arms, and then we're going to try to externally rotate them, and she's going to resist us. If that causes pain, it's often due to subscapularis tendon pathology. The final test for the subscapularis tendon is called the scapular liftoff test. We'll ask Jen to place her hand on the small of her back and just lift her hand off her back. Now if she can't do this, there's a significant problem with the subscapularis. We're going to do this against resisted isometric testing again to see if there's pain elicited with that maneuver. It would mean problems with the subscapularis tendon.